Hi, I'm Greg Botta from the University of California, San Diego. Today we discussed colorectal cancer at ASCO 2022, both in the curative and metastatic settings. In the curative setting, we evaluated the use of immunotherapy in deficient mismatch repair rectal cancer patients as part of a total neoadjuvant therapy program. And that was able to show that immunotherapy given alone in patients pre-selected for MSI high disease was able to achieve clinical complete responses that were durable up to approximately 2 to 3 years. Ongoing studies will evaluate the durability of that in that population, but it's important because it may give our patients the ability to avoid chemotherapy, radiation, and surgery. In addition, we also discussed ctDNA evaluation of therapy decision-making in stage 2 colorectal cancer. In this study, patients were randomized to ctDNA guided treatment or standard of care. What was found was that those patients randomized to use of ctDNA as a guide for care versus standard of care showed no difference in their recurrence-free survival. And importantly, those patients who were ctDNA negative with low-risk disease had an excellent survival outcome, the recurrence-free survival approximately 96%. Those patients who were ctDNA and were positive and then also got treatment, those patients actually did very well with recurrence-free survival in the 80% range. And we showed that that actually is important because patients who have ctDNA positivity without chemotherapy have approximately a 20% recurrence-free survival. Importantly, the patients who are T4 with ctDNA negativity did similarly to those who were ctDNA positive. So it's important to take both the ctDNA as well as the pathologic risk factors into account when deciding on your treatment responses. In the metastatic setting, we focused on the left-sided versus right-sided tumors, as well as patients who are RAS wild type versus RAS or BRAF mutant. In the patients who were left-sided RAS wild type, we found that a doublet therapy with panitumumab given intermittently had a very good outcome and considerably similar to patients' response rates in getting continuous panitumumab with chemotherapy. Importantly, what we found is the progression-free survival was increased with intermittent therapy, and the toxicity, including skin as well as diarrheal and electrolyte abnormalities, were decreased. Quality of life improved. So in those patients with left-sided RAS wild type, using a doublet therapy backbone with panitumumab intermittently will give you good responses and good tolerability. We also talked about how increasing or the intensity of a doublet to a triplet regimen with panitumumab in that same population doesn't necessarily increase responses. In the mutant and BRAF mutant patients, right-sided, we did discuss how FOLFOXIRI plus bevacizumab does induce greater responses. However, if your patients cannot tolerate FOLFOXIRI, using a doublet of FOLFOX or FOLFIRI is quite appropriate with bevacizumab to get responses. We ended up with oligometastatic patients getting to improved R0 resections. However, if patients are diffusely metastatic, it may not make sense to use all of your therapy upfront with FOLFOXIRI Avastin to try and induce a response where it would be better to maybe use serial FOLFOX followed by FOLFIRI or vice versa. And then in addition, we talked about the paradigm study that reiterated what was found in FIRE 3, that left-sided colorectal cancer patients initiated on chemotherapy plus panitumumab did better than if they were initiated on chemotherapy plus bevacizumab. And at the end of the day, I think that all of these studies helped us understand in our patients when to intensify therapy, when to de-intensify therapy, which patients can avoid chemotherapy, radiation, or even surgery. And additional prospective studies in both ctDNA guided treatment, immunotherapy, and rectal cancer, as well as colon cancer, are ongoing. What this means for patients are that everyone who presents to their oncologist should do so with definitive information that helps guide your treatment. Is your colon tumor on the left side of the colon or the right side of the colon? Have you had molecular evaluation of both your microsatellite instability or mismatch repair proteins, your RAS mutation or your RAF mutation? Further, is your clinician using ctDNA to help guide your treatment response? All of this information is important to help personalize your treatment approach, such that you're not just getting chemotherapy because everyone gets chemotherapy. You're getting the right intensity of chemotherapy based on your molecular profile, and in fact maybe even avoiding it based on your instability of microsatellite.